Welcome to the next in the series of Natera's webinars. Today's webinar is a deep dive into the utility of personalized MRD monitoring. My name is Bob Hansen and I'm today's moderator. Some housekeeping notes before we get started. Today's webinar is being recorded. You can ask questions at any time during the presentation by typing in the questions panel in the interface and clicking submit. We encourage you to ask questions early and often. Today's presenter is Dr. Angel Rodriguez, Medical Director Oncology at Natera. Dr. Rodriguez attended Baylor College of Medicine and is a board-certified medical oncologist who specializes in breast medical oncology and conducted clinical research with circulating tumor DNA. Before joining Natera, Dr. Rodriguez practiced at Austin Cancer Centers and Houston Methodist Cancer Center, where he was Director of Clinical Trials Office and the Triple-Negative Breast Cancer Clinic. Now I'll turn the webinar over to Dr. Rodriguez. Go ahead, sir.
Thank you, and welcome everyone to today's webinar titled Deep Dive into the Utility of Personalized Molecular Residual Disease Monitoring, where we will provide insight into real-time molecular monitoring with Signatera in the care of patients with cancer. My name is Angel Rodriguez. I'm an Oncology Medical Director at Natera. So in today's webinar, I will offer an overview of Signatera and review 4 abstracts that were presented at this year's ASCO virtual meeting. 2 of these abstracts are related to colorectal cancer. The first, a real-world look at molecular residual disease rates in colorectal cancer, and the second will review outcomes of patients with colorectal cancer who are tested with Signatera. The third abstract will demonstrate Signatera's performance in predicting treatment response in hepatocellular carcinoma, and the fourth abstract will emphasize the importance of filtering CHIP mutations in ctDNA analysis. Signatera is a circulating tumor DNA test created by Natera, a company that has been a leader in cell-free DNA technology for many years. We have now performed over 2 million cell-free DNA tests worldwide. Natera has offerings in reproductive health with Panorama, which is a test for non-invasive prenatal testing to detect fetal-derived ctDNA, organ transplant health with Prospera, a test to identify early kidney transplant rejection by detecting donor-derived ctDNA, and now in oncology with Signatera. All 3 of these tests leverage the same core technology combining novel and unique methods of multiplex PCR, along with our proprietary statistical and bioinformatics models for detection and characterization of the signal of ctDNA that we're looking for. That technology is described and protected with over 80 patents and have been described in over 50 peer-reviewed publications in top journals. It's important to note that there is a spectrum in the use of ctDNA testing in oncology. On the left side is the potential to screen asymptomatic, healthy, and unaffected individuals with the goal of early detection of cancers that don't currently have effective screening methods, or it could improve existing screening modalities such as mammography or colonoscopy. On the right side is the current use of ctDNA in the metastatic setting, where typically the tumor burden and concentrations of ctDNA is high. This is what is typically referred to as liquid biopsy to detect mutations that have been linked to therapy benefit or treatment resistance. ctDNA is particularly helpful in this setting, especially when there is little to no tumor available. Shifting to the middle of the slide, identification and measurement of molecular residual disease is where Signatera's strength lies and where we have focused our clinical research. Precedence of MRD by Signatera after best standard of care curative intent treatment can identify a population of patients that are destined to relapse. You can think of it as a way to monitor our patients with solid tumors, the way that we have been monitoring our patients with leukemias for decades. Signatera can also be used as a surveillance tool for early molecular recurrence monitoring longitudinally. Serial testing can identify recurrences much earlier than our current standard of care surveillances tools such as CT scans, biochemical tumor markers, and of course, clinical symptoms. Identification of patients with molecular recurrence can allow us to manage these patients with an intensive imaging surveillance program, which could lead to detection of local, regional, or oligometastatic disease that, when treated, can lead to prolonged survival and potentially a second chance of cure, as in colorectal cancer. MRD recurrence could also offer a window of opportunity where patients who are asymptomatic are destined to recur and have no treatment options to prevent that recurrence could be directed to participate in clinical trials with MRD as an entry criteria. Finally, the third area we focus on with Signatera is treatment response, monitoring, and early prediction of benefit. I will show how the dynamic changes of ctDNA and its correlation with treatment benefit can change the landscape of how we design clinical trials and evaluate treatment efficacy. Additionally, ctDNA dynamic changes can complement clinical information and help clarify clinical scenarios where we have to balance the risk and benefits of our treatments in a setting of unclear benefit. For example, in the setting of having equivocal imaging findings. In order to achieve this unique, personalized, and tumor-informed approach with Signatera, a sample of the patient's tumor tissue is required in the initial setup along with the patient's blood sample. This approach differentiates Signatera from other liquid biopsy tests that have a tumor-naive or a tumor-non-informed approach and don't take into account the genomic profile of the patient's tumor. Knowing the patient's tumor-specific mutations allows us to dive deeper into circulating cell-free DNA to find the molecule of circulating tumor DNA. The first part of the test process involves performing whole exome sequencing on the tumor tissue and match normal DNA from each patient. Based on these results, we can identify the differences and create a molecular signature of tumor mutations that are unique to each patient's cancer. We look at all of the somatic tumor-derived mutations and apply our proprietary algorithm to select the most important or the most clonal single nucleotide variant and custom design and manufacture for each patient a personalized multiplex PCR assay that is going to target the top 16 clonal mutations found in the tumor. We do frequently get asked, why 16 genes? But it is not just about the quantity of genes that we select, but rather the quality of the genes that we select. Also, the answer is relatively simple. The less number of genes that we are looking for, the harder it is to find. So a lower number of genes leads to a decreased sensitivity. However, the higher number of genes, the more likely we are to find tumor-related genes, but at the cost of lower specificity or false positives. Basically, the more you look, the more you find, but not necessarily what you're looking for, and so it increases false positives. We have found that 16 is the best number to maximize both our sensitivity and specificity. But again, it's not just about the quantity of the genes, it's also the quality of the genes. So oncogenes, for example, are more likely to be lost over time to selective treatment pressure, whereas passenger mutations or clonal mutations are more likely to persist over time. Additionally, our library prep and our sample prep efficiency derived from years of experience in the cell-free DNA technology is where Signatera's performance comes from. In the plasma, we used a personalized PCR assay to amplify those 16 targets and then sequence to detect presence or absence of that patient's tumor DNA in their blood. The mean of the detected target then become the reported result as a mean tumor molecules per milliliter. Essentially, Signatera becomes a patient-specific tumor marker that can be used for the rest of the patient's life, from diagnosis to surveillance to monitoring metastatic disease if it occurs. Signatera's clinical performance has been validated in several tumor types. Shown here are the results of Signatera's prognostic performance in 4 of our publications, including colon cancer, breast cancer. Our initial validation study was published in Nature, and it was in lung cancer. and also in muscle-invasive bladder cancer. Patients represented in these 4 Kaplan-Meier curves completed curative intent treatment. If patients test Signatera positive, with enough follow-up, these patients' cancers almost always recur. Whereas if a patient tests negative and remains negative with serial testing, only a few of those patients' cancer will recur. These studies demonstrate that Signatera can identify micrometastatic disease in patients that will experience disease recurrence. And these 4 publications reveal that Signatera can perform better than traditional high-risk factors that we currently use to predict recurrence. So our first abstract, presented by Dr. Pashtun Qazi from the University of Iowa Healthcare, and conducted in collaboration with Colorectal Cancer MRD Consortia. It's titled Tumor-Informed Assessment of Molecular Residual Disease and its incorporation into practice for patients with early and advanced colorectal cancer. Now, before we dive into the data, the question is, this data will give us a real-world look into Signatera MRD rates of positivity. And I want you to think about what are the expected relapse rates of patients with low risk versus high risk stage 2 colon cancer, or low risk versus high risk stage 3 colon cancer. Signatera MRD positivity rates should reflect these expected relapse rates. So in this study, 715 samples from 535 unique patients were collected and tested as part of an early adopter program. The large majority had colon cancer, 432, followed by 77 patients who had rectal cancer and 27 who had lower GI, such as appendiceal and small bowel cancer. 57% of these patients were male, and the average age of the cohort was 61 years old. This study evaluated the relationship between ctDNA status and clinical outcomes, including radiological imaging and multivariable analysis was performed with all clinical variables. Post-surgical ctDNA detection was significantly associated with stage of disease. So notice here that 7 out of 68 patients who had post-surgical MRD assessment, or 30 days after surgery, roughly, 10.3% of patients had stage 2 disease had detection of molecular residual disease, whereas 19 out of 71 patients, or 26.7% of stage 3 disease, had MRD detection. Signatera MRD positive rates approximated expected relapse rates within each risk stage of disease. Now, some of these patients had adjuvant chemotherapy. Some of them did not have adjuvant chemotherapy. This was at the discretion of the treating physician or at the acceptance of the patient. Now, MRD, when we look at the stage 2, within stage 2, MRD detection rates in patients with T3 stage 2 was 5.6%, whereas if it was T4, the MRD positivity was 28.6%. And accordingly, in stage 3, patients with low risk stage 3, they had an MRD rate of 9.3, but if it was high risk stage 3, it was fourfold higher at 39.4%. And additionally, several patients, 5 patients with rectal cancer undergoing neoadjuvant treatment had ctDNA testing, and 4 of them had detectable ctDNA. And 6 patients had detection during the adjuvant therapy or surveillance period. So also notice that unlike other ctDNA tests, we report results as mean tumor molecules per milliliter of blood, as opposed to variant allele frequency, which can be affected by background cell-free DNA levels. And I'll show you how these levels can be caused by surgery, by post-surgical trauma, and affect the results. And quantity detected range from 1 mean tumor molecule per 10 milliliters of blood all the way to 8,700 mean tumor molecules per 10 milliliters of blood. Also, notice that post-surgical levels of ctDNA did not correlate with stage of disease. Multivariate analysis revealed that T4 status versus T1 through 3 was the only statistically significant covariate associated with ctDNA positivity in this study. In the metastatic setting, the Signatera assay was able to detect circulating tumor DNA in all 16 patients with active metastatic disease. In patients where there was documented stable disease or partial response, 9 out of 15 had detectable disease. So obviously in this setting, knowing the trend would be important to know whether a patient, may potentially be benefiting for treatment or not. Let's see. And then in the setting where patients had no evidence of disease, MRD rates were 4 out of 12, 33%. Close follow-up with surveillance and monitoring the trend in ctDNA would be helpful in those with MRD positivity, whereas those with recurrent ctDNA negativity, may possibly be offered, treatment de-escalation or discontinuation with close monitoring, especially in the setting of prolonged Signatera. It's a prolonged remission, as is the case with exceptional responders. So Signatera can be helpful in determining treatment benefit or resistance, especially in those patients who don't have a detectable or reliable tumor marker. Moving forward, in the setting of oligometastatic disease, in this study, 93 patients who had oligometastatic disease were tested, or 93 samples, I'm sorry. Patients who had oligometastatic disease had ctDNA detected 9 out of 9 times before surgery. When tested after surgery, the ctDNA positivity was 49%. And if they were tested while on treatment, 1/3 of the patients tested positive. So these post-surgical results, again, consistent with expected relapse rates, allow us to better inform patients of risk of recurrence. However, more studies are needed and are ongoing to determine if patients who undergo treatment of recurrence of oligometastatic disease benefit from chemotherapy or not, and whether there is a difference in benefit in patients who test positive versus patients who test negative. It's important to note that the timing of the assay is important. This was evaluated in this study. If the sample is collected within 2 weeks after surgery, notice on the left-hand side, or the figures, the solid black dots, levels of cell-free DNA are higher post-surgically, so related to post-surgical trauma. This can lead to lower MRD detection rates due to high background noise. So these graphs illustrate that the ideal time for initial post-surgical draw is after about 3 weeks of treatment. MRD rates in patients with colorectal cancer across early stage oligometastatic colorectal cancer and metastatic disease reflect expected relapse rates and demonstrate treatment response dynamics in a clinically useful way. Now, moving forward, our second study was presented by Dr. Noelia Tarazona from Incliva Biomedical Research Institute at the University of Valencia, and it was conducted in collaboration with Aarhus University Hospital collaborators in Denmark. And it is titled ctDNA to detect minimal residual disease in response to adjuvant therapy and identify patients at high risk of recurrence in stage 1 through 3 colorectal cancer. The goal of this study was to expand on a previously published colorectal cancer data set to further validate use of Signatera ctDNA assay to detect MRD in colorectal cancer patients at high risk of recurrence during and after adjuvant chemotherapy. We also sought to determine the molecular lead time of recurrence between ctDNA detection and radiological imaging. 198 patients were enrolled 193 cases were analyzed with a median follow-up of 21.9 months and ranging from 1.4 to 41.9 months. Most cases, 103, had stage 3 disease, 85 had stage 2 disease. Patients had baseline Signatera performed 1 month after surgery and every 3 months thereafter. 1,052 plasma samples were collected and analyzed, and Signatera results were then correlated with outcome. As you can see, Signatera performed exceptionally well in this study. ctDNA positivity, post-op, and longitudinally were associated with worse outcome. On the left, when looking at the results of single time point Signatera testing 30 days after surgery, 78.5% of patients who tested positive had relapse of their disease, and only 9.2% of patients who tested negative had a relapse, negative of a hazard ratio of 14. In the middle Kaplan-Meier curve, illustrating patients who were tested after completion of adjuvant chemotherapy, so only patients who were treated with adjuvant chemotherapy, a positive result yielded a hazard ratio of 27.9, or these patients who tested positive were 28 times more likely to have a clinical relapse. Post-adjuvant MRD positivity is indicative of treatment-resistant disease and identifies patients in need of better than current standard of care treatments. These results highlight the importance of incorporating MRD positivity as an eligibility criteria into novel clinical trial designs. The third Kaplan-Meier curve on the right includes all patients, including patients who underwent and didn't undergo chemotherapy, whether it be by patient or physician choice or recommendation. And notice here that the hazard ratio was 47.5. Let's see. So we also looked at lead time and longitudinal ctDNA status was associated with a lead time of 8.15 months. So in general, all these, these results show that a positive Signatera result is indicative of micrometastatic disease that is destined to relapse within a follow-up. The clinical value of knowing this information will allow you to enroll these patients in either intense surveillance programs, where a multidisciplinary approach will allow you to find the potentially curable oligometastatic recurrence and treat it accordingly with surgery or radiation therapy. And alternatively, identification of patients with treatment-resistant disease could help identify patients who are best served with a referral to a clinical trial. So multivariable analysis was also conducted with traditional risk factors that are currently used in the clinic. It revealed that longitudinal ctDNA was the only significant risk factor for recurrence of disease. Now, currently, there are several prognostic risk factors that are considered in the clinic when oncologists decide to recommend chemotherapy, or when patients accept chemotherapy or not. And these high-risk factors are shown here. In some cases, the risk-benefit ratio is clear, but in many circumstances, it is not. Decisions to recommend 3 months of chemotherapy versus 6 months of chemotherapy, oxaliplatinum chemotherapy versus omission of oxaliplatinum chemotherapy can sometimes be challenging and may also depend on the age and comorbidities or side effects that the patients may experience. Incorporation of tumor-informed ctDNA in the decision-making process may tilt the balance one way or the other. Molecular residual disease status should be incorporated in the design of novel clinical trials that are aiming to address these issues and aiming to address treatment resistance with either escalation of treatment or trials that are aiming to improve long-term quality of life without compromising chance of cure by de-escalating treatment. Finally, the results of these two studies do highlight the importance of incorporating ctDNA status in the next generation of colorectal cancer staging systems. Shifting gears to hepatocellular carcinoma, which is the third presentation presented by Dr. Chi-Hung Shu from the National Taiwan University Hospital, and it's titled Longitudinal and Personalized Detection of ctDNA for Monitoring Treatment Response with Atezolizumab plus Bevacizumab in patients with unresectable hepatocellular carcinoma. In this study, the investigators sought to explore clinical trials applications of Signatera monitoring in patients with advanced hepatocellular carcinoma treated with immunotherapy. Longitudinal and personalized detection of ctDNA for monitoring the treatment response to atezolizumab and bevacizumab in patients enrolled in a study G030140 was evaluated. Baseline and post-treatment ctDNA levels were analyzed in relation to treatment response. Patients were classified into subgroups before Kaplan-Meier analysis and Cox proportional hazards modeling for PFS and OS. Baseline samples prior to treatment were collected. ctDNA high versus low was defined relative to the median, and ctDNA absence or presence was determined after one cycle and after 3 cycles of treatment at cycle 2 day 1 or cycle 4 day 1 respectively. And response was assessed by IRF RECIST 1.1. Samples were also collected at progression of disease. So this study led to a larger study called the IMbrave 150, which was the first randomized phase 3 study in more than a decade to demonstrate a statistically significant and clinically meaningful improvement in overall survival with atezolizumab plus bevacizumab versus sorafenib in this patient population. This combination is now a preferred first-line treatment for patients with unresectable hepatocellular carcinoma who had not received prior systemic therapy. This phase 1b study was what was used for our analysis. So 48 patients were pre-selected to represent each treatment response group. So 10 patients with complete responses, 11 patients with partial responses, 12 patients with stable disease, and 15 patients with progressive disease were selected for analysis. Personalized Signatera assays were successfully designed for 98% of the patients in this treatment group, or 47 out of 48 patients. Detection of ctDNA was seen in 96% of the patients and 45 of 47 patients. And the median ctDNA levels were 70.6 mean tumor molecules per milliliter with a median variant allele frequency of 1.8%. Shown here, baseline ctDNA levels is associated with tumor burden and treatment response. So larger tumors had higher ctDNA baseline levels. Additionally, increased baseline levels of ctDNA were observed in patients who had ultimately had progression of disease compared to those who had a complete response. Post-treatment ctDNA levels are dynamic during treatment, so we can measure these changes. Most responders, those who had complete response and a partial response, most of these responders had decreased or non-detectable ctDNA levels at cycle 4 day 1, whereas ctDNA levels in nearly all non-responders either increased post-treatment or remained above detectable levels. Progression-free survival was significantly better in those patients who tested below the median as compared to those patients who tested above the median when looking at either the results of Signatera drawn at the beginning of cycle 2 or 3 weeks after one dose, or at cycle 4 day 1. Rapid identification of patients who did not benefit from treatment was achieved by knowing high ctDNA levels after just one dose of treatment. Also, longer progression-free survival and overall survival were observed in patients whose ctDNA changed from present to absent post-treatment. Clearance of ctDNA after 3 doses of the combination resulted in excellent progression-free survival and overall survival. So overall, these results illustrate the promise of ctDNA as an emerging biomarker for patients with hepatocellular carcinoma, but also, it gives us some insight into the potential for future design of clinical trials and evaluation of novel agents in a much more cost-efficient way. Our last poster is titled Characterization of Clonal Hematopoiesis of Indeterminate Potential, or CHIP for short, mutations from germline whole exome sequencing data. And this was presented by Xin-Ta Wu from Natera. Clonal hematopoiesis of indeterminate potential is an age-related phenomenon where somatic mutations accumulate in cells of the blood or bone marrow. We leverage the thousands of samples that are sent to us to evaluate the prevalence of CHIP mutations by analyzing the whole exome sequencing data from the Buffy code of 1,104 patients diagnosed with various solid cancers. The most common CHIP mutations that we observed are DNMT3A, which is commonly known. 81 patients had identification of that gene. TET2 and TP53 were the second and third most common genes that were seen. Now, interestingly, CHIP mutations were not observed in patients younger than 20 years old, but they increased in frequency and with every decade of life thereafter. The incidence of CHIP increased from 10% for the 20 to 29 years of age group to 25% for age groups older than 60 years old. Among patients who had undergone treatment prior to sample collection, CHIP mutation incidence was lowest in patients who were treated with targeted therapy at 9%. Compared to those patients who had received prior cytotoxic treatment, 18% of the patients had detectable CHIP. And patients who had chemoradiation had 21% of those patients had detectable CHIP, and it was highest in patients who were treated with immunotherapy. So the Signatera assay filters CHIP mutations through tumor tissue and germline sequencing, thereby ultimately reducing false positive results, and it focuses on tumor-specific mutations for each patient. And with that, I end my talk, and I can take any questions.
Okay, great. Yes, we do have a bunch of questions, so we'll just take these one by one. As a reminder, if you have an individual question that you'd like to ask of Dr. Rodriguez, please do that. Someone from the audience appreciates all the data that you went through very succinctly and quickly. So
Thank you.
Let's start with first, what is the turnaround time for your initial test, including whole exome sequencing?
Sure. So, the first step is the initial setup test. So in that test, we do require tumor tissue. So requesting that tissue and obtaining that tissue goes into the turnaround time. Ultimately, roughly about 3 weeks is what it takes for us to be able to give results back. And then subsequent blood draws after that, since we don't need, to request tumor tissue, 1 week is the turnaround time.
All right. Next question. Do you report actionable mutations in your test results?
So the way our test works, we do not report actionable mutations. We specifically, our proprietary algorithm selects non-pathogenic or passenger mutations that are unlikely to be related to proliferation or apoptosis. And this allows us to have genes that are consistent throughout the life of the tumor and are not lost throughout the life of the tumor. So we do not report actionable mutations.
Okay, next question. Someone had to leave a early, but they're going to catch up with the recording. Do you have contact information where folks can reach out to you offline?
Absolutely. I think, let me see if I can show it here. There you go.
Okay.
Please. Yeah,
All right.
so email and phone number are there, correct.
Okay, good. All right.
Thank you.
We'll dig into the questions now. Some of these questions are going to reference back to the specific studies that you went through, so I'll just read them to you. Hopefully they're clear. We can either ask folks to re-ask the question or take it offline if it's not clear. So
Okay.
the next one is, can you comment on the stage 1 MRD rate of 13%? It seems higher than expected.
Sure. So number one, it is a small number of patients that were tested, and this was not in sort of all-comer stage 1. You know, these patients with stage 1 disease were tested for a reason. So I think there probably is a selection bias of sort of higher riskish stage 1s. So I wouldn't make too much of, the 10% detection. I think larger studies ultimately will very likely prove that the detection rate is much lower than the small number of patients that were tested in that study.
All right, next question. How do you assess the clonality of mutations from a single lesion biopsy?
Let's see. So it certainly is part of our proprietary algorithm that not only looks at the genes and what they do, but we also look at the levels of those genes. And so genes that tend to be more clonal will have higher levels at detection. But it goes more. There's more to that is part of the proprietary algorithm that allows us to develop Signatera.
All right, next one. What is the relationship between the top 16 cloacal mutations found in the tumor versus those found in plasma?
Sure. So these same 16 genes that we find at the initial time point that allows us to create and manufacture the personalized and tumor-informed assay for each individual patient are the same 16 genes that we check throughout the serial testing and longitudinal testing for the rest of that patient's sort of course of monitoring. And so, we select 16, and we may not always detect all 16 levels, but certainly, with our algorithm, we can find out whether the result of our analysis of our multiplex PCR ultimately translates to a positive result. So, but it is the same 16 genes that we find that we ultimately develop in that first assay.
Okay, this one might be related. Have you observed differences between the 16 variants selected in the primary tumor versus the metastatic tumor?
So we don't dig deep into looking at all the differences that happens when we generally this test is done on just one biopsy, right? We don't do a biopsy on the metastatic setting and a biopsy on the primary. We would prefer the primary if it's accessible, but this test can be designed on the metastatic one. So no, and if we do it on the metastatic, then we do the 16s there. So we don't have data to compare what happens in the metastatic or the primary, but we're confident that our algorithm can select for 16 truncal clonal mutations, whether they are derived from the primary biopsy or the metastatic lesion. And a lot of the data that I showed you includes some patients who the assay was designed from the primary tumor as opposed to the metastatic site that was biopsied.
Okay, excellent. How do you explain why SDPR had a lower MTM score than NED?
STPR. Say that again.
SDPR.
STPR.
Yeah.
Oh, okay. Ask that again. Stability.
Yeah. I'll just read it the way it was written. How do you explain why
Go ahead.
SD/PR had a lower MTM score than NED?
Okay. So obviously, patients that what we don't know is the trend of what the level is. So quantifying, which we do report quantity in this study, we're just reporting positive versus negative, but the ultimate dynamic change is probably more important to know. So the level might be higher, but the previous test that was done before, you might be able to see that there is a trending down of the result of MTM per milliliter, which would be consistent with a partial response.
Okay. How was MRD defined in the first study?
The first study, okay, so molecular residual disease detection is when we do a serial blood draw at any time point that actually if we find the variants that are on the initial design, that we call that a positive result, molecular residual disease. When we find the variants that were originally selected.
Okay. The next one. How distinguishable is the MRD signal from DNA derived from dying cells caused by chemotherapy or lysis syndrome?
So sure. So the clearance of ctDNA within the body, or the half-life, if you will, is actually quite short, in the matter of hours. So certainly, if we would have drawn, and we wouldn't recommend this to draw the test, an hour or 2 or 3 after administration of chemotherapy, we would detect higher results. But nevertheless, the effect of the chemotherapy, would ultimately last over several weeks, and ultimately the ctDNA levels kind of stabilize over time, especially in responding patients.
Okay, great. We have a lot of questions here, and as a reminder, for questions that we don't have time for, we'll follow up with you individually. So I think we'll go with this one as our last question, Dr. Rodriguez. Is Signatera able to detect the emergence of resistant clones that were not part of the top 16 in the primary tumor prior to treatment?
Sure. At this point, Signatera does not look for any other alterations other than the 16 original clonal or truncal mutations that make part of the assay.
Okay. Great. Can you stay on for just one more question, Dr. Rodriguez?
Yeah, go for it.
Got the last
Yes.
one that I think we can handle here.
Yeah, go for it.
Do you think that the ultimate clinical use of MRD will mirror the 4 existing responses, CR, PR, SD, PD, or reflect the binary labeling that you have shown in your studies?
I think certainly in the setting of MRD, it's what's important is the binary sort of positive or negative. If a patient ever tests positive for Signatera, these results reveal that we've detected micrometastatic disease that with enough follow-up are destined to relapse. In the setting of treatment response, I think levels are going to be more important, and knowing whether there's a decrease in ctDNA or there's an increase, or even better, if there's a clearance, which our data also shows that these patients will have a better outcome.
Okay, excellent. Well, on behalf of our audience, I want to thank you for your presentation and sharing the data and adeptly handling the questions.
Thank you, Bob. Thank you.
Yeah. Again, questions that we didn't have time for today will be forwarded to Natera for individual follow-up. And at this time, we will end the webinar, and you may now disconnect. Thank you very much.
Thank you.